Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hi, my name is Francisco Rivas, and today we will talk about the imaging features of intradural extramedullary lesions. This slide illustrates the three key compartments where spinal cord lesions can occur, each with distinct imaging features. First, intramedullary lesions are located within the cord itself. The intradural extramedullary lesions, they are located within the thecal sac but outside of the spinal cord. Then the extramedullary lesions are located outside of the thecal sac, still within the confines of the bony canal. Understanding the lesion location relative to a spinal cord and meninges is crucial for narrowing the differential diagnosis and guiding management. Let's begin by reviewing the objectives for today's session. First, we will focus on identifying the most common types of intradural extramedullary tumors. Next, we'll explore the clinical and genetic associations. We will also discuss key imaging features. The goal here is twofold. First, to help you tailor your diagnostic considerations to a single most likely diagnosis. And second, to identify imaging features that may suggest aggressive biologic behavior, such as heterogeneous enhancement or rapid growth. We will then turn our attention to discuss conus lesions. These have particular characteristic imaging features. Finally, we will cover the importance of nodular intradural enhancement in the setting of known primary malignancies, as it strongly supports the presence of leptomeningeal metastatic disease. Okay, with these objectives in mind, let's dive into the content. This example demonstrates an enhancing intradural extramedullary lesion that shows dural tails. The axial images help us localize the mass in the left anterior quadrant of the thecal sac. It also describes this central notch, described as the jingle leaf sign, which is the impression created by the presence of the dentate ligament. This is a case of a spinal meningioma. Spinal meningiomas are one, if not the most common intradural extramedullary tumor. The majority are low-grade tumors. They have a strong thoracic predilation, and they also show a female predominance. There is also an established association with prior exposure to ionizing radiation. Finally, 98% of spinal meningiomas present as solitary tumors. So, if we encounter multiple meningiomas, we should consider other possibilities like neurofibromatosis or metastasis. This case shows multiple spinal meningiomas and a spinal cord ependymoma and bilateral vestibular schwannomas in a patient with neurofibromatosis type 2. Multiple spinal meningiomas will occur in approximately 2% of patients. If there are multiple meningiomas will be associated with neurofibromatosis type 2, which is linked to the deletion of the neurofibromatosis type tumor suppressor gene that is located in chromosome 22. Here we have an intradural extramedullary mass that demonstrates cystic features, peripheral thin enhancement with a focus of nodular enhancement. This lesion is centered in the left posterior quadrant of the thecal sac. This is a case of a spinal schwannoma. Spinal schwannomas are typically solitary and sporadic, accounting for about 95% of their cases. Only about 5% are multiple. usually in the setting of neurofibromatosis type 2 or schwannomatosis. They most likely arise from the dorsal spinal nerve root and can present with radicular pain. Imaging may show hemorrhage, cystic change, or fatty degeneration, especially in those larger lesions. Compared to neurofibromas, schwannomas are usually eccentric to the nerve, encapsulated, and displace the nerve. This is another case where we see multiple intradural extramedullary masses that are hyperintense on T2, hypointense on T1, and demonstrate significant enhancement. This is a case of multiple neurofibromas in a patient with neurofibromatosis type 1. Neurofibromas may occur sporadically or in association with neurofibromatosis type 1, which is important to recognize as it significantly increases the risk of malignant transformation. A classic feature is the target time on T2-weighted sequences, where we see a hyperintense rim with a central comparative lower T2 signal. Due to their slow growth, they may lead to scalloping of adjacent bone. They can be found intradural or paraspinal, and when they extend through the neural foramina, they may take on a dumbbell configuration. The plexiform variant is distinct for its back of worms appearance. In contrast to schwannomas, neurofibromas are often unencapsulated and fusiform and involve the nerve itself. Here we have a patient with NF1 who has bilateral plexiform neurofibromas in the lumbosacral plexi. This patient developed this large mass with necrotic components and hemorrhagic blood product deposits. This is a case of malignant peripheral nerve sheath tumors, which are aggressive sarcomas with about 50% associated with NF1, 40% occurring sporadically, and 10% following radiation exposure. They typically arise from large and medium-sized nerves, and most are larger than 5 cm at time of diagnosis. Here we have a sausage-shaped mass that demonstrates avid enhancement and heterogeneous signal intensity both on T1 and T2 weighted sequence. This is a case of Myxopapillary ependymoma, which is a slow-growing variant of spinal cord ependymomas. They are located in the conus and account for 83% of tumors in this anatomic region. It's very important when it comes to myxopapillary ependymomas to evaluate for involvement of the conus, as it can significantly affect surgical planning and management. This is a patient with multiple metastases in the coracoid nerve roots and a known glioblastoma in a patient with leptomeningeal metastasis. Leptomeningeal metastasis can be present in up to 5 to 8% of patients with solid tumors and up to 5 to 15% with 15% of patients with hematologic malignancies. Interestingly, only half of patients with leptomeningeal metastasis will have a positive CSF cytology. So when it comes to imaging, MRI of the total spine is considered the most accurate modality, with a sensitivity of 70% and a specificity of 77%. Leptomeningeal metastasis is associated with a poor prognosis. Well, the time is coming up, but I would like you to take home these 6 points. First, meningiomas and schwannomas are the most common intradural extramedullary tumors, and both are associated with NF2. Meningiomas are most commonly seen in the thoracic spine, and they do show a female predilection. Neurofibromas are most commonly seen in the cervical spine, and they will be associated with NF1. Malignant peripheral nerve sheath tumors mimic the imaging of a nerve sheath tumor, but has more aggressive behavior. Myxopapillary ependymomas have characteristic imaging features based on the pathology, and nodular intradural enhancement in the setting of a known primary strongly support the presence of leptomeningeal metastasis, even in the face of a negative CSF cytology. And with this, I would like to thank for your attention. Bye.